Welcome again, day two of the PAHLCA meeting. We had a wonderful exchange of ideas yesterday, and we hope to continue that this morning. I'll be moderating part of the morning discussion together with my colleague and friend Luann Hatton. So, our first speaker today is an old and very dear friend. And is particularly useful for this dialogue because Landry Sagwe is both a former UNICEF regional advisor for HIV and now currently the director of primary health care at Africa CDC. So, Landry, you understand both sides of this HIV into PHC equation, and I know that you're going to lead us in a wonderful presentation this morning. So, Landry, over to you. Let's hear your perspectives.
Good afternoon. Can you hear me, Shafiq and colleagues?
Loud and clear, Landry. We hear you perfectly.
Excellent, excellent. No, thank you so much. It gives me great pleasure to join this critical and timely conversation. I bring warm greetings from Addis Ababa and from Africa CDC. I also want to commend the organizers of this symposium. I think the PAHLCA 2025 could not have a much better team enhancing pediatric and adolescent HIV person-centered care, integrating HIV services into routine health services for quality and sustainable health outcomes. I understand this is a fully virtual event, so I want to warmly greet all the participants from where you are participating in this symposium. But I want to particularly greet the people of Uganda, I think the host country for today's this symposium since yesterday. At Africa CDC, we are looking at HIV, especially in this context where we are fostering integration of HIV services within primary health care. We are looking at pediatric and adolescent HIV as a priority agenda for integration and a priority agenda for elimination. So I would like to really commend the organizers of this conference for prioritizing this topic and also for bringing the right experts and the right stakeholders around the table. I know we have representatives from government, we have representatives from civil society, we have representatives from the development agencies, UNAIDS, WHO, UNICEF, and others. I think this is the right mix of stakeholders we need for this conversation. So let me start by stating what is obvious, but what is sometimes, overlooked is the fact that you cannot talk about universal health coverage. You cannot talk about elimination of new HIV infection, or you cannot talk about UHC for pediatric HIV care and treatment without talking about primary health care. And you cannot deliver primary health care without country leadership. So for too long, our health systems have treated pediatric HIV or adolescent HIV as an afterthought. Let me put it bluntly this way, especially in the context of the integration agenda. But if we are serious about universal health coverage today, and if we are committed to ending AIDS, particularly pediatric AIDS, then our starting point must be the child, must be the adolescent who are the most underserved in this context. So Africa CDC believes that primary health care is not just primary in terms of the entry point. We believe it is the priority level of service delivery if we want to achieve equity, if we want to foster prevention, and if we want to prepare our community for outbreaks and epidemics. But the reality is sobering. I think I'm sure yesterday you went through some statistics. So when you talk about integration, the basic tenet is the system within which you're integrating the service. And if you're looking at the primary health care facilities in our continent, in some countries, close to 60% of primary health care facility will lack basic electricity, basic water and sanitation services. And in most cases, they are ill-equipped to consistently deliver continuous services for HIV prevention, treatment, TB screening, and more importantly, managing the comorbidity that comes with HIV care and treatment. So it's precisely where we need to intervene at primary health care. Why? Because that's where 90% of our health needs across the life course should be met. It should be met at primary health care. And that's why at Africa CDC, we place a priority for primary health care transformation. We place it at the center of our continental health security agenda. We place this agenda of primary health care transformation at the center of the universal health coverage vision. And yes, it includes strong integrated HIV services tailored to the needs of our children and our adolescents. So the Africa CDC Peace Transformation Agenda builds on 6 pillars, which are not far from the WHO pillars. But these pillars include workforce, with a focus on the community health workers. The second pillar focuses on infrastructure and digital tools transformation. The third one is on the commodity security, with an emphasis on local manufacturing of some of our commodities used at primary healthcare level. The fourth one is financial access, with an emphasis on domestic resource allocation to primary healthcare services. The fifth one is around quality and data. I think the theme of this symposium also brings an important component on quality when we are integrating HIV services at primary health care. And the last one on the list is around governance and accountability, with an emphasis here on coordination at all levels, with an emphasis on the agenda of Lusaka, which brings in the component of one plan, one budget, one M&E framework, one reporting mechanism, really fostering alignment around national priorities. So at Africa CDC and African Union, we are working to advance an agenda of 2 million community health workers by 2030. We are already halfway. The biggest challenge now in the context of global financial reduction towards public health programs is how to sustain the momentum and how to secure the gains. Because at the end of the day, as we foster integration of HIV within primary health care, we have to transform the way we approach the workforce at primary health care levels. And CHW, Community Health Workers, definitely going to play a critical role in maintaining continuity of services, ensuring quality of services, especially for the most vulnerable children and adolescents. I also want to emphasize on 2 elements that we're working on as Africa CDC is on the digitalization of primary health care. It's an important agenda and it will allow member states and countries to develop interoperable systems that can link community data with facility data, ensuring that no child living with HIV is lost between point of care. We're also working on supporting the development of climate resilient primary health care infrastructure. I mentioned earlier the challenges that primary health care facilities are facing in our context. So we are prioritizing solarization, connectivity, and access to capable cold chain management for all the commodities, vaccines, and of course, in this case, we are talking about pediatric HIV commodities as well. So let me, as I wrap up this point, remind our dear participants that integration isn't only about a process. Integration, especially when we look at it from an HIV perspective, it has to be a paradigm shift. because it can be a challenging process if you look at it only from the perspective of bringing the HIV program within another platform. We have been operating at primary healthcare level when it comes to HIV. We have been operating at community level for most of our HIV programs. But today, when we look at integration, we need to really look at it from moving from siloed approach to a people's person-centered care. I think the theme of this conference is also aligned with that vision of person-centered care. We want to look at it as a way we are moving from vertical funding streams to more aligned, accountable systems under one national plan, one national budget, as I was referring to. And at Africa CDC, the head of state of the continent requested that we implement the Lusaka agenda, which calls for exactly the one plan, one platform, one budget, one team, and one reporting system. And the Lusaka Agenda Monitoring and Accountability Framework, which was developed by member states and Africa CDC and other stakeholders, will effectively monitor how our member states are going to support that shift, which is also linked to domestic resource allocation to the health sector. So finally, I think we need to talk about trust. I'm sure when you look at the integration, at the end of the day, it's about coming together. And in any relationship, trust is going to be critical to build. HIV program managers, getting more comfortable with what you may want to call the other program managers for other prevention and treatment programs as part of the broader PHC package of services. Yeah, they will have to trust each other, to work together, to put resources together. Because at the end of the day, if we are committed to a people or person-centered approach, we have to work as a team behind that child, behind that adolescent. And in a system that is based on trust, I think we are also more likely to reduce stigma towards people living with HIV by bringing that comprehensive package of intervention to those in need. So let's say we are not short of ideas in the space of HIV. We know what to do. I think what we need more now is a political commitment towards integration. What we need more is to think about scale of the approaches that we want to implement. We have to be committed to that because investing in community-based, epidemic-ready primary health care will only bring significant return on investment. For $1 that we will spend at strengthening our primary healthcare systems, we are likely to have $10 in return through reduced disease burden and improved productivity. So I invite all of us today to commit to have children at the center, children and adolescents at the center of our primary healthcare transformation and reforms. We have to commit to embed HIV services into everyday primary healthcare functions, especially at the community level. We have to push for pool and flexible funding. I insisted on increased domestic allocation to primary health care, which will also foster integration of services. And we have to really emphasize on accountability, and we need to be accountable to the community we serve in this process. So let's not wait for another crisis before we are reminded that a strong primary care is not only our first line of defense for outbreaks and epidemic, but it's also our first line to fast-track progress towards universal health coverage, to fast-track our progress towards elimination of new pediatric HIV, to foster our progress towards universal health access to universal access to pediatric HIV and adolescent HIV treatment. I thank you. Back to you, Shafiq.
Landry, thank you very much for those very clear thoughts. I especially like this idea that it's not just primary healthcare, it's priority. It's the priority level that we need to focus on in order to achieve UHC. You talked about some of the pillars that we need to focus on, and one of them was around the digital aspect of digitizing, if you will, primary healthcare. And that's a great segue into our next speaker. So let me hand over to Lou Hatan, who's my colleague and friend at PATA, to introduce our next contributor. Thank you. Lou, over to you.
Thanks, Shafiq. Thanks so much. So yes, just privileged to welcome Anna Jakuzik, who works in the Data for Impact Department at UN AIDS, and she is importantly going to be presenting on data systems for integrating health services. Sorry, I think my camera came on a little late, but welcome to Anna. Thanks.
Thank you so much, Luan, and thank you everybody for having me. And such an important conversation given the circumstances the programs are facing due to the loss of funding and also sustainability of data systems as we are observing. I just want to check with Luan if you can see my screen well.
Yep, we
see
can
everything and we hear you perfectly.
and hear you great. All good.
Okay, and the panel is on the top of the image with audio, video settings, or you don't see them?
I can't see the panel. Are you meaning in terms of translation, interpretation for that?
The Zoom panel that is in the middle of the screen, but I'm trying to push it aside. Apologies for some.
We see your screen very clearly.
Thank you, Shafiq. Thanks so much.
I think I can see at the bottom, Anna, the points for moving on. Is it working? The little pointers, I saw them a minute ago. Now they've disappeared.
Okay. Yeah, that's what I was struggling with for a moment. So today I was asked to present on the data systems for integrated pediatric and adolescent HIV services, where countries are in terms of advancing their data systems and data quality, as well as using different tools for understanding the landscape of HIV across different types of the populations. My presentation is heavy in terms of resources. I've provided an overview across different frameworks and types of the data that are available, but also considerations that we are having at the global level when observing the data system from the reference group standpoint and data quality and methods. So please bear with me. All the references are provided together with the frameworks that we are considering while looking at the current landscape. So just a quick reminder on why we need systems and why the systems are critical in terms of addressing child health, pediatric HIV, and also adolescent HIV. And this is one of the reasons that we consider this systems approach critical, is that adolescents and children are lagging behind adults and across different age groups in terms of HIV care cascade. So the gaps in child and adolescent outcomes are quite severe, and this is something that speaks also to the quality of the data and the program outcomes. So it's combined, and the better data we get, the better understanding of where we are, we can get at the national level, hopefully subnational level in some places, and a global level. Here on this side, you can see the estimates from last year's exercise, EPI estimates 2024, where we could see that 1.4 million children were living with HIV globally, mostly in sub-Saharan Africa, and 1 million adolescents were living with HIV at the end of the 2023 year, based on the last year's estimates. And only at the population level, if we look at denominators as people living with HIV or children living with HIV by age group, we can see that 57% of estimated number of children living with HIV were receiving treatment, and 64% of adolescents. So those are the lowest outcomes across different age groups, and is a concern for the global response, and also across countries where the outcomes are poor. In some places, the outcomes are different, so I wanted to emphasize that the progress differs across countries and also regions, and those are the global level estimates. Also, 120,000 children and 140,000 adolescents were newly infected with HIV in 2023. So I just wanted to start with the key frameworks that we have globally across partners. WHO leading all global standards in terms of surveillance and data, routine data systems, as developed led by WHO together with partners such as UNICEF, UNAIDS, and academia and all different experts in this area. So I wanted to highlight a few of those that are related to pediatric HIV and vertical transmission programs, as well as to highlight the global AIDS monitoring framework that combines all different types of indicators, including vertical transmission programs and integrated care for selected areas of focus. So you can, and I'm sure you are all familiar with those frameworks, but just a quick reminder that this is the foundation of the surveillance in pediatric HIV and also vertical transmission programs, and how to measure success of our programs. One of the examples and one of my favorite summary of key patient monitoring tools on the left, you can see how to monitor the PMTCC cascade across a range of service delivery settings, including preconception, pregnancy, labor and delivery, and postnatally, and how important it is in principle to get a system that has referrals and linkages across ANC or primary health care and PMTCC services and maternal and newborn and child health services across in a way that would be transparent and also at the national level presented in a way that is reliable and robust. Data systems track HIV testing, treatment, viral load suppression across different age groups, and also by gender. We look at retention across maternal and pediatric care. We also support integration within different types of service delivery platforms, including primary healthcare, as I mentioned, MNCH, and elimination of vertical transmission programs across service delivery points. So this framework also highlights the need for triple elimination across HIV, syphilis, and hepatitis B virus within primary healthcare settings. We do have some systems to track services across 3 diseases and measure how and to which extent pregnant women are affected by one or several of those diseases, and the transmission rates and positivity in infants based on this data across diseases. Something that I wanted to highlight as an analysis of challenges that we are seeing, as well as some highlighted opportunities for more streamlined data across different types of programs. And I will go swiftly across those points that I wanted to highlight. Some of the points may apply or may not to specific contexts. So it really depends on the implementation at in different countries. However, some of them are quite frequent, and the need to address those challenges is really tough. It's been in the past, but also increasingly at the moment, since we have been seeing in high burden countries that data systems are affected, and it will be more and more challenging to collect the data at the national level with confidence that it is representative at the national level. So please bear with me as I go through those points that's been raised during the last reference group meeting that is led by UNAIDS on surveillance and modeling. So what we are seeing is the fragmented landscape for data. Data is often driven by donors, or otherwise it also complements national systems, like a separate system that is maintained by donors to some extent, or to a great extent in some places. We see that the data, and specifically around HIV surveillance, and what I speak about here is the surveys, DHS, SOPHIA's. They are expensive, they are infrequent, donor-driven HIV surveillance that was an amazing resource for everybody to understand the prevalence across age groups. However, given the lack of resources, we will be having less information coming from HIV surveillance. So we need to find a way or opportunities to maintain surveillance in the way that would be affordable for countries, but also sustainable going forward. Program data, when we speak about program data, and routine case surveillance and routine program data, we often see incomplete data due to reliance on paper-based systems, inconsistent reporting across facilities, and we also see barriers such as stigma, parental consent requirements for adolescents, and lack of youth-friendly services that also limits the uptake of testing services and later linkage to care. It doesn't only affect the service provision and service and coverage across different types of services, but also data systems. And also, given that even in highly successful programs in countries with great, if I can say so, case surveillance and routine data systems, we often see the use of paper-based systems, which limits real time and also triangulation across facilities, and at the national level, double counting may occur for different types of indicators that also limits our understanding, often also skews the results of the program outcomes. So there's a bias in data that we also see, bias in use of methods to estimate vertical transmission or MTCT rates, etc. Often the data bias stems from political background and how the data needs to be presented at the national level. And it is actually being discussed also by partners and experts. And the issue is not in the bias, but rather in understanding the bias and also understanding what needs to be done to address this bias. what kind of opportunities we have across those challenges that I've highlighted in order to move our data systems and our understanding of the programs towards more transparency and also sustainable approach, meaning country-owned, driven by countries predominantly. And this is something that I wanted to highlight as a critical way forward. We see that we need to improve routine data systems and case surveillance based on the frameworks that's been outlined as global standards by WHO and partners and experts. We also see an opportunity in sentinel surveillance for PMTCT programs. Sentinel surveillance was used in the past extensively before we moved towards routine data systems to measure prevalence in pregnant women, and now we are seeing that it can be combined in a way that would make the prevalence in pregnant women more transparent and robust in understanding our epidemic and vertical transmission. We also see that we need a more rapid and community source data for key population surveillance, including for sub-Saharan Africa. The groups that would be included in the key vulnerable populations would be adolescent girls and young women. In other places, key populations would also be other types of groups depending on behavioral patterns or risk behaviors, including we want to highlight BBS slide for HIV for surveillance and behavioral surveillance in key populations that can be utilized for more rapid and community sourced data. Colleagues also mentioned technology and digitalization, definitely a way forward, highlighted in most of those guidelines. They need to use technology and also training staff to build country-level capacity in order to be able to use technology and data digitalization is necessary. And we are hoping that countries will be able to push this agenda forward. We also suggest using tools and statistical methods to identify and account for bias, so gaps in data. And those tools are available at the country level. Some countries are using one type of tool or several types of tools in order to understand where they are at the population level. I will touch base on those, but definitely there's no way to rely only on programmatic data in order to understand where we are or trends or over time or population level estimates without using statistical methods. So the other group of challenges and opportunities that we see, I want to highlight is on the right side on my slide. Lack of interoperability across data systems, meaning that, for instance, tracking patients across care transitions such as pediatric to adult care or just across the facilities and pregnant women or children makes it difficult for colleagues to understand the data clearly, and it creates often double counting and loss to follow up or silent transfers. There's layers of issues that occur just because we cannot track unique identifiers. So current systems also often rely on delayed data entry, and as I've mentioned, using paper-based systems, which also delays our understanding of what's going on in certain places. There's also another layer of issues with poor internet access or technology access, especially in rural areas across countries. Some opportunities that I would like to highlight here also is to build on previous gains and data systems that's been put in place, also with help of our donors and partners. We need to make sure that HIV surveillance is integrated in broader, more general surveys, since we are seeing that DHS or FIAs won't be carried out in the nearest future, and we need to find a way to address population level estimates for prevalence and integrate HIV in those existing surveys that can integrate the HIV questions in them. Implement unique identifiers. Everybody speaks about this, but we don't see being implemented at scale. Geospatial models clearly would highlight geographical issues and hotspots. We need to develop and tailor national data systems in a way that speaks to local contexts. Meaning that data systems need to be connected in a way that the data shows national level estimates and not fragmented to certain facilities reporting while others not. So thinking through this data system in a way that would integrate the data system entirely and not fragmentally across subnational levels. We need to also enable data exchange between EMR and national systems, so somehow related to the previous point. We do recognize also looking at the tools that we have and the data systems that are made available at the global level. I wanted to highlight two. One is Naomi model as an example output for Malawi. As you can see, subnational level prevalence here. We believe that using subnational level estimates going forward and strengthening our systems in a way that they would be able to inform our HIV landscape even better is the way forward. I also want to just highlight for those who are not aware, and I'm sure that most of you are, that data that comes through the global AIDS monitoring framework that we validate and we establish together with our partners, with the WHO and UNICEF, and we validate the data together, is available. So this data is available at AIDS Info. It also has parameters or indicators that are related to integration, such as those related to elimination of vertical transmission. You can see on the left side indicators, and all of those labels are drop-down list of different indicators, so you can explore those. And elimination of vertical transmission, we have HIV, TB, syphilis and hepatitis B. We also have TB and HIV separately, hepatitis and HIV for hepatitis C in people who inject drugs, and also cervical cancer and HIV in terms of integrated care services that are outside of the vertical transmission programs. And here I've provided some references that you can explore. Those are new thinking on how to build different types of data systems and surveillance. Also application of digital tools for adherence in different countries across Africa, adolescent HIV care, and innovative service delivery and data collection methods such as telehealth innovation in HIV care, and some ideas that may be useful while tailoring your data systems at the national level. Thank you very much, and over.
Thanks, Anna. Thank you so much. Just sharing all of those challenges and opportunities for streamlining data. I think it gives, I won't say a small window, quite a big window into the system complexities that I think many of our countries are having to manage, make decisions around, and try and establish priorities, which particularly at this time. I think in the interest of time, I'm going to try, I've looked at some of the questions in the chat, and I'm going to try and present two questions, one to yourself and also Dr. Landry. But it's very evident that systems are going to be needed if we're going to keep children at the center of the primary healthcare transformation agenda. And yet, from some of the things that, Anna shared, just we still continue to see quite fragmented or donor-driven systems. So I think my one question maybe initially to Dr. Landry is just, in terms of where we're moving with primary healthcare transformation, what frameworks do you think are in place so that we could leverage upon to be able to ensure some movement or accountability in being able to integrate some of the HIV service surveillance that potentially could get lost? So that's one question to Dr. Landry. And then, of course, I mean, if in short, I think there's a question obviously around, the transformation of primary healthcare and still concerns around user fees and what the implication of that. But then just for you, Anna, just in terms of the opportunities that you identified, and I think, sort of highlighting sort of subnational data and how that could be optimized. But if countries really had to prioritize or really focus on one or two things, what would be those one or two things that you think could be real game changers when we're faced with limited resources and countries can maybe only focus on one or two opportunities to take forward? So if I could ask Dr. Landry to deal with the first question, and then we'll go back to Anna, and then I imagine we would be within our time. Thank you so much.
Thank you so much. I think these questions around how do we keep the agenda of primary healthcare a priority in this particular time, and how do we keep ourselves accountable, is very close to the Lusaka agenda that I mentioned in my talk. Maybe to keep things simple, allow me to share one slide which clearly articulates what the Lusaka agenda is about. It's a slide that summarizes what is called the 5 strategic shifts of the Lusaka agenda. And you can see that from the left to the right, the first strategy shift, which was endorsed by our head of state in 2024 as a priority agenda, as member states are also facing the transition from various global health initiatives, which has an impact on most of our programs, including HIV. The first shift is that primary health care should be strengthened through a health system approach. And then the second shift is one that now catalyzes the role and the sustainability of investment with a focus on domestic resource allocation. And that is where the barriers to access becomes critical, because I think you mentioned how do we deal with user fees, how do we deal with sustainability of HIV program in face of the reduction of donor support. This is the shift where governments are requested to increase domestic allocation, and donor support is requested to align with national priorities as we sustain programs, including HIV programs. Then the third one is very much the one that now looks into equity, scale, and access to the most vulnerable. This is where integration takes a critical place. This is where we are looking at how do we, for the case of HIV, how do we reach the most vulnerable and the marginalized populations. Then the fourth shift now calls for, this is much more targeting the global health initiatives, and it's requesting global health initiatives as they provide support to member states to foster operational coherence. That will include minimizing the burden to countries as those countries apply to those global health initiatives in terms of mobilizing resources from those initiatives, or as they implement also programs that are funded by those global health initiatives, with an emphasis on utilizing national systems for program implementation, as well as for financial allocation and financial management. And the last one is very close to the agenda of commodity security, which now brings in the whole spectrum from research and development to local manufacturing. And there are now indicators that the Africa CDC and African Union, working with partners, have prioritized. These indicators are being finalized. I'm just going to flag the 10 key scorecard indicators that are currently being finalized, which will be utilized now to foster accountability around the 5 strategic shift of the Lusaka agenda. So these are those indicators. They are still being finalized and will be validated with our member states, and they'll be monitored with member state reporting on an annual basis on how they are evolving across those 10 indicators, which are somehow measuring how the countries will move into the implementation of the 5 strategic shifts that I described earlier. Over. Thank you.
Great. Thanks, Dr. Landry. I think we're all going to be strong advocates and supporters of one plan, one budget, one reporting mechanism. I think for far too long we've been needing to get behind that agenda as a continent. But I want to give the last word to Anna, just in terms of some of those opportunities and priorities, what her recommendation would be, and then that would be to close the meeting, because I think we're running a few minutes over time. But just to thank both of our speakers as well, and just opening day two with such clarity. Thank you. Over to you, Anna.
Thank you so much, Luan. So in terms of priorities, I want to highlight that we have already started seeing challenges in routine data collection. And it would be, for us going forward, really difficult to disentangle where the services were affected by the funding cuts, or data systems are affected in a way that countries cannot report properly on the number of, for instance, pregnant women tested at antenatal care, or early infant diagnosis in children, or initiation of new women on treatment for PMTCT. So those data systems, they need to be sustained going forward, and more increasingly with the efforts of country-level colleagues and staff, meaning that even if data systems were predominantly supported by donors, this process needs to be taken over and sustained, because it will be very difficult and increasingly difficult to understand what is going on with the programs and to interpret this correctly. So my call would be to sustain routine data systems and case surveillance, as well as just for a broader agenda to also think how to measure the burden and prevalence at population level if we are losing surveys. So finding opportunities to integrate HIV in general surveys, as well as applying perhaps sentinel or consider applying sentinel surveillance from PMTCT programs as an addition to routine data systems. So this will be my priority that I wanted to highlight with the group. Thank you.
Thanks, Anna, and just a clear reminder, just in terms of gains already made, that we need to make sure that these are not compromised. So just in prioritizing some of that routine data, the case surveillance, and of course, I think any of the transformation and the prioritization and adaptations that are going to happen, that these, need to be well thought through, planned, and managed. So just in the interest of time, just want to thank both yourself and Dr. Landry for a great opening session for day 2 of our PAHLCA meeting, and just handing over back to Dr. Eleanor. Thank you so much.
Thank you very much, our chairs, for the first session. We are now going to move into the second session. I would also like to take this opportunity to thank our speakers for a great discussions. I will now turn it over to Stephanie to give us an overview of what we're going to do in the nominal group technique. And she will also invite Isaac to give us some IT guidance before we get into the nominal group technique. Over to you, Stephanie.
Great. Thanks so much, Dr. Eleanor. And good morning, good afternoon, colleagues. Excited to jump into this session, and apologies that I can't go in video. I'm traveling and don't have great connection, but hopefully you can hear me clearly. So the goal for this session it's called a nominal group technique, as Dr. Eleanor has explained, and the goal is really to drive forward a structured process to generate ideas, prioritize them, and reach consensus among participants around some key questions related to integration. And the goal here is to really try to gather responses from all delegates on the call, and do more of a deeper dive into different topics related to integration, using a set of different questions from yesterday. So, and really encourage everyone to share ideas and thoughts, as we really want to encourage participation across the board. So with that, I'll turn it over to Isaac to take us through some of the logistics.
Hello, everyone. Before you is a poll. Are you able to see the poll?
Yes.
So please kindly respond to the questions. You can type in whatever you believe is a response that suffices the question, and we'll gather these responses and share with us here so that we understand how we proceed in some of these guidelines. Thank you. Steph, I will hand over to you. You could maybe read through some of the questions so that people, as they type in, once you finish typing in, you should be able to click submit, and then we'll have those responses, and we'll flash them once we end the poll. I do not know, Chair, how long this is supposed to run. You can guide. Chair?
Great. Just looking back at our agenda. So I would say that we should spend about 5 to 7 minutes going through the questions. Feel free to write sentences or bullets or words even. The goal is to really generate as much ideas as possible, and then we'll aim to synthesize the key themes that are coming out of this exercise. So let's take the next 5-ish minutes to fill out the poll. Thanks so much. And while you're writing, I can just read through the questions. So the first question is around what models or frameworks have you used in your country to implement guidelines for the integration of HIV services into primary healthcare? I'd also encourage you to share any thoughts or ideas around that specifically relate to children and adolescents living with HIV, given the focus of this summit. Number 2 is what processes have you developed and or utilized to support the implementation of these guidelines? So really thinking through kind of end-to-end implementation in country from the national level to the community level. The third question is, what have you learned through the application of these processes to support the implementation of integrated HIV service guidelines into PHC settings? And then finally, what recommendations do you have for other teams who are looking to implement such guidelines in their countries?
So once you're done, click submit, and then we'll be able to review some of the answers in the next 5 minutes. Since we had about 5 to 7 minutes, we should be back reviewing your responses. Thank you. Two more minutes. Kindly summarize and click submit. 2 more minutes, please. 1 more minute, kindly summarize, submit your your responses, and we'll be able to read through them here. Thank you. Our response rates are still low. We'll allow for more of you to submit. Kindly submit, respond appropriately, and submit. Yeah, should we end the poll or we give a little more time? 20% of the participants have responded. Chair?
Okay, thanks for that, Isaac. Let's see. So we don't have too much more time, so maybe we can stop here and start to summarize the responses and look at some of the key themes coming out. So we have about a little under 10 minutes left of this session. And Isaac, are we able to see the actual responses to each question? If they are anonymized?
Yes, I'm trying to load them. Just be patient.
Great, thank you so much.
Apologies, my connection is relatively slow. I'm trying to load them, but just a minute. System has not yet picked them from Zoom, but 1 more minute maybe. Okay, they have loaded, sharing them shortly. Are you able to see my screen?
Yes, we can see it. Thanks so much, Isaac. Great. So I might at this point pass over to my co-chair, Janet, who can take us through summarizing the responses that came out of this exercise. So over to you, Janet. Janet, can you hear us okay? Okay, in the interest of time, I can just keep going, and then Janet, let me know if you're able to jump in. But Isaac, maybe if you could scroll down just to see some of the longer form. Great, great. Okay. Okay, so just quickly reading through this, I think, something that's coming out strongly to this first question is really thinking about task shifting or staff rotation, especially when thinking about integrating packages of care at different entry points in the facility. There was a mention of champions and mentor mothers to help with care linkages. I see multidisciplinary teams called out, which is definitely really important in thinking through integration. Then there's a mention of a lot of different DSD models to facilitate integration, as well as at the point of service delivery, as well as following up clients directly. Incredibly important, and especially as we think about what types of models are most impactful and efficient in the current landscape. So maybe we can look at number 2 quickly. What processes have you developed and or utilized to support the implementation of these guidelines? So maybe we can stop at the word cloud right here. So I'm seeing sensitization come up. Isaac, if you could scroll up, that would be great, just so we could focus on the looking at the word cloud might be easier to digest in real time. Isaac, if you don't mind scrolling up. Great, perfect. So yeah, I'm seeing sensitization coming up, training of trainers, standard operating procedures, stakeholder engagement, supervision. Yes, all of which are really critical to catalyzing implementation at different levels of the health system. And then maybe Isaac, if you can scroll slowly down through the responses, just seeing if there are specific other pieces to call out here. Yeah, I think a lot of the same themes that I just talked through are highlighted. Okay, number 3. So this one is around what are the lessons learned with regard to application of these processes to support implementation of integrated care. So here it might make sense to look at the long form responses. If you could scroll down, that'd be great. Okay. Okay, I'll highlight some of the responses coming out here. So someone has highlighted, leveraging resources, including physical space in most facilities to improve efficiency, an observation of generally reduced stigma at facilities since all patients receive services from the same points, though highlighting the potential risk of congestion in some cases. The use of proper appointment management and DSD models might help the challenges around management of data systems. Around management of services, though data systems are still somewhat fragmented, which Anna was highlighting as well in the last session. And yes, another really important point there around the importance of giving enough time dedicated to proper planning and sensitization, since as was highlighted before, this is quite a significant paradigm shift in the way that services are structured. So then just in the last minute or so here, so what recommendations do you have for other teams looking to implement such guidelines in their countries? So we've seen comments here around working closely with governments and fostering political goodwill. The need for proper leadership, using a clear framework, regular engagement of stakeholders, KPIs on integration. That's a really important point, just to understand whether integration is having the intended impact. Routine supportive supervision and performance review have been highlighted a number of times across questions, and thinking about how to, smartly and effectively reprioritize human resource gaps and repurposing health infrastructure. Yeah, and then this last point is a really good one as well. So really trying to maintain that visibility around bottlenecks related to supply chain management and service delivery to ensure that integration is happening in the way that it's intended and that patients aren't being lost in the process, especially when we're thinking about such, fundamental changes to service delivery design. So some really good insights here. Thanks so much, everyone, for your participation and sharing some really insightful comments in response to these questions. We can do some work after the meeting to summarize and synthesize the findings and share those around more broadly. But really appreciate people's participation in this session. Isaac or Dr. Eleanor, anything else that we wanted to cover here? I think we're about at time.
I think we've covered that. Dr. Eleanor, do we move into the next session? I think Dr. Ellen has dropped off. I can't seem to find her. Just 1 minute. But maybe in the meantime, even as we wait for her to rejoin, do we have someone that probably would want to raise their hand and maybe give a response to some of the information that is coming out from the data that we have collected here? If you want to raise your hand, you probably feel your point may need you to verbally say it. Just raise your hand and we'll call you out and you'll be able to give that response. anyone that would want to say one or two things? Okay, Dr. Leno is trying to rejoin. She has a connection issue. But we can probably move into the next session. I do not know if the speaker for the next session is on Dr. Joseph Kavanda from CDC, together with the co-chair, Nicole Flowers. Nicole, are you there? Or Dr. Joseph Kavanda? Nicole, Joseph Kavanda.
Yes, there's actually been a change in the plans for this session in terms of who's going to be the section host. I will no longer be hosting. So I think we have to wait on Dr. Eleanor. I think she was going to reassign it. But I'm not sure about Dr. Joseph.
Dr. Elena is failing to join. I would propose then we could probably move into the next session where we were to have strategic discussions, country integration chairs. Nicole, I do see you are in one of room 1. Patricia, are you on? And Joseph Kabanda in room 3. Do we have all these participants? We get into our breakout rooms now. Nicole, Patricia, and Joseph.
Similar, I still am not going to be hosting the next session. I'm not sure about Patricia.
Let's just be patient. Maybe we take a 2-minute break as we try to get our chairs back on. And after that 2-minute break, we should be able to get into our breakout rooms as we get our chair back. Thank you. 2-minute break. Please do not drop off the call. We have some more interesting discussions. Thank you. Colleagues, do not drop off. We're just taking a quick break. We shall return shortly. Thank you. Okay, Dr. Eleanor is back. She's been able to find a connection. And Dr. Eleanor, we were done with the session where we're reviewing some of the data that was coming from the discussions on how people would want to see integration. We have had some break here over the last maybe 2 minutes or so. We took a coffee break. We would then, I think, proceed into the next session, which ideally is supposed to be the breakout session for strategic discussions of strategic discussions about the country integration. I will hand over to you, Dr. Eleanor. Thank you very much. Dr. Eleanor, can you hear me? Are you able to hear me? Dr. Eleanor, can you hear me?
In the breakout sessions. I'm now going to invite the rapporteurs to give us your summaries. Please limit yourself to 5 minutes at most. So anyone who is ready can go first. Chairs, kindly support us to have the rapporteurs, the session chairs in the different groups. If you can support us to have the rapporteurs project their slides. Over to you.
So apologies, we don't have slides. We just have like, we just took notes and we're just gonna read out. Sorry.
That's okay, ma'am. Please go ahead.
Okay, so from our group, response to the first question about the processes, the discussion will focus on the Uganda implementation process, They first had a pilot phase, which took a year to develop. They had a proof of concept that was able to focus on sensitization and planning of what an integrated healthcare service in primary healthcare would look like. They then had to try and figure out all the issues pertaining to service delivery, quality of care, and stigma. What they felt was that facilities were very different. They could not have a one-size-fits-all approach. They used a QI approach to try and fit in what each facility would require in terms of leadership, facility, and teams development and involvement. So you can see that they needed to design an implementation strategy that would A, fit various facilities, B, not interrupt health services, 3, help to sustain existing laboratory services and different health systems that were already running, so clinic days and delivery of services, as well as patient flows. And then also try to mitigate some of the challenges they would meet, especially stigma, because now, for instance, drugs would be dispensed from one window. So they had to sort of find an approach to that. After they streamlined all the issues in that pilot phase on patient flow, capacity building, leadership, and and identification of services and factors that would enable ease identification of factors and processes that would reduce stigma. They then went on to design the actual implementation phase. As far as I'm aware, they've told us that the regional implementation took place 3 weeks ago, and then currently it's the district level implementation that is happening, and their next phase level for facility implementation is going to happen very soon. It's going to be spearheaded by the district leadership, and this will be supported by the regional referral systems that are in place, as well as their MOH implementation partners. So that's regarding the first question. And then the second question was about lessons learned. So the key lesson that we learned is that they felt that the whole process was very rushed. And because it was very rushed, there were lots of consequences that occurred. Number one, there was disruption of services offered to patients, which led to poor access of HIV services, including like sometimes patients not coming for viral load and not coming for counselors. So they quickly realized that they required to do step-by-step process implementation. Number two, they realized that it was very important to have differentiation of health services. They realized the one-size-fits-all, like I said, was not possible. Number three, capacity building. They needed to assess and build their capacity properly, and also assess supply chain, laboratory services, and clinical specialist involvement, as well as focal person involvement, because at the time there were already clinics that were running but not participating in these HIV services, and suddenly they were supposed to cope and try to do everything. And so some teams were not coping. They were referring lots of patients to regional facilities. So what they then did was to improve their sensitization processes on patient adherence and description of roles, and supporting patient populations with issues regarding stigma. They also then had to try and make sure that they still help staff to understand the differentiation of services, so that they were able to say where PMTCT was already happening, let's say on a Tuesday, and diabetic clinic on a Friday, and other services on a Wednesday, they keep to those days, but support staff to offer the relevant facilities. And they're saying their approach was very much a QI approach, and they made sure that they improved transition of services without forcing them, but supporting them slowly. And lastly, continuous quality improvement and doing root cause analysis on implementation and lessons learned on the management of patients. Attitude of health staff was very key. Understanding the leadership from the key leaders to the foot soldiers on the ground carrying out the work was also very key. Having a buy-in of leaders both at the top level and in the small, in the facilities on the ground was very key. And they also learned that the leadership didn't just need to be at health system level, but political leaders and also other stakeholders, because they realized that in Uganda, the political leaders, the opinion leaders have as much influence as the health service leaders, and having a buy-in meant all these political leaders and opinion leaders became ambassadors. And the last point was the role of community health workers. They are not always there in every facility, but it seems in Uganda they've got village health committees with all these people who are very pivotal in health systems and managing and signposting others to the referral systems and active services. Lastly, on recommendations, number one, planning was very key. They recommend strictly that what worked in Uganda may not work in other places, but nonetheless, planning is essential for any team. So we need to balance intensive planning with not starting. They advocate that we should not take too long, but as well at the same time get started. Number two, they encourage that we should focus on context because it matters. As I keep saying, one size does not fit all. Number three, recommendation was the implementation of differential delivery of services, understanding what is required for the PAHLCA, DSD models, and all the things that we've discussed in the other two points, and managing the potential problems. So you can imagine with integrated health services comes the issues of congestion and maintaining of services at the same time. And they've also learned that technical support supervision is very important. So technical support supervision includes mentorship. It also includes understanding of new varied methods of working and regular engagement of all stakeholders. So this is very key. And number five, sensitization. The people living with HIV had certain expectations of how they needed to be treated and managed, and the fact that there was stigma, just giving of drugs from, like, let's say one dispensing window was an issue. So all these issues need to be considered in any facilities that is going to adopt integrated health services. Number six, establishing clear flow flow of patients for facilities. As I said, context will be key here. Others will use integrated OPD flows. If you're using OPD flows, make sure that the health facility designs, not just coming in and telling them what to do, but the actual people working in the health facilities in the OPD should decide where patients should go, who will be involved, and what role they will have, and all that. Number eight, understanding that there has to be SOPs that are developed. So they were just telling us why it was important to develop SOPs, so that people should know exactly what services are going to be delivered, by whom, how, and what's supposed to happen. Number eight, just even basic things like just having teams that will think of any other things, potential problems that could come in. They were given an example of screening. They even had to do basic things like just coming up with a pathway and acronyms for who has been screened, who has not been screened, and who would then take on who has been screened and needs HIV testing and who hasn't. Lastly, they focused on the issue of leadership so much that they felt that without leadership, all this cannot happen. In Uganda, the leadership is very strong, and the whole case of Uganda implementation worked well because the Ministry of Health in Uganda just issued a strong memo from the Permanent Secretary of Health, who then sent this memo to the whole district leadership, not just district health officers, but political representatives, accounting officers, and everybody else. So it was very easy for everybody in the political arena, in the community arena, and the health arena to accept this. It became an easy buy-in. When the technical teams came to try and teach them, it was something that had already been accepted by all cadres. So lastly, confidentiality. Always remember confidentiality. The patient is at the key of all this. Involve peer networks. The people living with HIV have networks, have peers and other expert clients who support their services. They all need to be sensitized. They all need to know how the system is working and how they can improve. Do not abandon everything that we've built on in the last 20, 30 years as HIV programs, but embrace all that and try to make it work with this new integrated HIV care, and then things will work better. Thank you so much. over. Sorry, did you hear that?
Yes, thank you very much, Maggie. I think Dr. Eleanor is dropped off. I don't know whether again, but thank you for that. Maybe a request to the other rapporteurs in the other rooms to kind of slow down, because we may need you to, we need to have the interpretation. So it's our request that when you're presenting what you discuss in your groups, you kind of slow down so that the interpreters have a bit of time to both listening and do the translation. Thank you. Let's have the other room as well. I don't know which number that is. Luwen, I see your video is on. I don't know whether it's you going.
Yeah, thanks. Thanks, Isaac. Sorry, it was all, we had to sort of just adjust things a little quickly. So I don't think we actually had an appointed rapporteur. So I'm gonna give it my best shot just to try and summarize some of the discussion. I think Maggie covered lots of that already, and her feedback was very well structured. So I'm apologizing. I don't think ours is going to be that well organized. But just from group one, there was just more of a general discussion. You know, countries were really in different places. I mean, I think sort of the Uganda example, you know, sort of leading the way in terms of integration, other countries, you know, just beginning, and people sharing sort of examples of existing programs where we've learned lessons in terms of integration. So obviously around your MNCH, or vertical transmission prevention, TB, sexual reproductive health, or adolescent-friendly services. So some sort of existing models or programs where integration had already happened and was working well. Those were shared. But what there were sort of two or three other areas of discussion that we came to mostly. I mean, the one, of course, I think like everyone has spoken about in terms of, you know, the leadership, the clarity, the planning, the clear guidance, the tools, standard operating procedures that are really needed to provide sort of clarity and guidance. I mean, as you can imagine, there's a big sort of gap between the guidance that could be shared, or the instruction, or the memorandum, to the actual operational implementation. And of course, you know, where we see the real challenges are really on the front line in terms of operationalizing some of those integration guidance. And of course, as people have already identified, you know, just the scope of work on often, you know, very few health providers all of a sudden, you know, being expanded dramatically, and this being really difficult. Or in instances where health providers weren't particularly, you know, trained in terms of HIV service delivery or working with children and adolescents, you know, how they can be upskilled quickly. So a very big sort of need and some discussion around how we can make tools and guidance available quickly, how we can cascade training in efficient and effective ways as well. But also just recognizing there are challenges in terms of some health providers being put under quite a lot of pressure. So big questions around capacity, scope, and ability to integrate service delivery without compromising quality care. And I think some, you know, broad questions again were asked around, in the integration, you know, do we potentially leave children behind, particularly where, do we have systems where we can have sufficient alerts in terms of children who might need additional differentiated service, and to pick up sort of children who are not doing well and making sure they don't sort of get lost in the process of integration. We had quite a big discussion around data and just sort of some of the challenges around that integration, with many in our group still sharing that the systems were really quite fragmented and not coming together. So really this need for more harmonization. Definitely, there would have to be more thinking around restructuring of data, some questions around the number of indicators being used and having to find a way for being able to still collect what's needed, but the importance of simplification, this real need for being able to track unique identifiers. So that was discussed, as well as, the importance of the utilization of data. So how, if we're looking at data really even at a facility level, how data can be used more directly to alert us, to being able to follow up on specific cases and clients, but also to lead our sort of quality improvement initiatives. So really not just the collection of data, and concerns around complexity, number of tools, and often this now falling on the same health provider who's having to deliver the service. So the scope of work for one health provider really is being expanded. And then the other sort of big sort of discussion area was around sort of care pathways and when we're looking at integration, really paying attention to some of the community and the task shifting and your community health worker scope of work. So, there's some challenges in that in terms of where we've seen impact on some of that sort of support network, having been disrupted in terms of psychosocial support, but also at the same time seeing opportunities for really integrating community health workers to be able to work across multiple disease burdens and then potentially really having, I don't want to say one cadre, but a very clear community health worker cadre who works in close collaboration with the health service in terms of being able to provide those additional services and support in the community. And making sure that we can still provide a differentiated service. And then I think just lastly, was this question around organization, and that, there is going to be an evolution and a reprioritization of so many things. And I think the question around, effective community engagement, what does that really look like? In this reprioritization of things and what is the evolution of community engagement and feedback loops look like. So I think historically, we have the health committees, how strong are those? How do we strengthen those? And do we integrate sort of the sort of HIV, CLM models into those sort of historical kinds of committees? And then I think we had a great example from Nigeria where, under their main network for people living with HIV, NAPWAM, I think it's called, they've really shown and led by example of how they were able to bring all networks and sort of key civil society structures under their one structure. So that really helped in terms of consolidate, streamline, and align the sort of community engagement and feedback and mechanisms in terms of task shifting under one very specific structure, where I think for other countries that's really more complex because you have multiple structures, civil society structures, so more difficult. So I think I'm not sure I've done justice to our group, but yeah, just as by way of summary, that was the main discussion. Thanks.
Thank you, Lewin. Dennis, I will give you maybe 1 or 2 minutes to summarize what they transferred to give some closing remarks. Dennis Kaliba, please unmute. You can use 1 or so minutes to summarize what did transpire in your room. Dennis?
Thank you very much, Isaac. Hope you can hear me.
Yes, we can.
Yes.
Please go ahead.
All right, so from group 3, we are able to look at the questions, and we had very interesting discussions from the group. So we had 3 countries sharing a bit of where they are. For example, we looked at Kenya being at the very beginning of the integration, but the integration is at different levels. We also looked at Nigeria, who have just completed the guidelines, and they are going into the implementation of the guidelines. And then Eswatini, where they are fully integrated, having a national reporting system. But of course, there are some challenges here and there, looking at the HR, the human resource being much affected by the stop work order. So we looked at the recommendation on, basing on where they are, each of them, and also from the different members sharing what they think that needs to be picked. So we looked at the digitization of the national data system, being that the initial systems were mainly donor funded, and being donor funded means that this system only capture what is of interest to the donor. So the integration should as well start from also consider integration of the data systems. We also looked at investing more in the capacity building for the health workers to be able to understand how they will be supporting all these components being integrated together. The other thing we saw is that there are some issues, the community drug distribution, specifically looking at how the integration will support, will be done in the community as they distribute the drug. So we discussed and realized that there's already local structures like the community healthcare workers. There's already the supply chain, which is for the primary healthcare services like immunization, and members thought there's also a good opportunity to go through these mechanisms to be able to integrate the services even at the community. The other thing we looked at is the leadership. We saw that looking at the district engagement, which is something one of the Ugandan members in the group shared, there is a need to strengthen leadership at all levels, looking at the district facility leadership. And this is in planning and oversight, and also clarifying on the implementation responsibilities across these groups. Lastly, which I can quickly talk about, is advocacy for local funding. We saw that in one of the countries, they're already advocating for an increased budget in the health, leveraging on this that will be able to at least try to close that gap. So this is also the other thing that can be included on the integration plan. I don't know if any other member of the group is able to say something. I hope I've represented what we discussed. Thank you, Isaac.
Thank you very much. I know we're a bit over time, but you should be able to pick a thumbs up, pick a hands clap for the presentations that did, various presentations that did take place in the various breakout rooms. Thank you, everyone. Our chairs, you just were chosen on spot, but we thank everyone, and we want to thank every one of you that has been here up to this time. I will invite Dr. Eleanor to come and close us out. We are really, really grateful for every one of you that has given in your time. Dr. Eleanor, over to you. Thank you.
Thank you very much, Isaac. Thank you to all our chairs, all the participants, all the presenters. We greatly appreciate you joining the call. And I'm going to be brief as I make the final remarks. PAHLCA 2026 will be held as a pre-IFASA meeting. We usually have the IFASA meeting in December, and we are tentatively planning for a meeting in South Africa. And given the current funding situations, we are planning for a combined meeting to have PAHLCA as a pre-IFASA meeting. IFASA is another meeting that we organize that is abstract driven. So we'll be communicating more. We want to encourage you to keep checking on the website for updates. We'll be posting the materials on the website in about a week, at most 2. You will also be able to access all the previous content. So please be active on the website for more updates. We are going to develop a meeting reports and also develop a best practices document. A small group is going to work on that, and we hope that through the discussions we'll come up with detailed guidance for the teams that can be able to that you can be able to use in your different countries, tailoring the document to your specific context. We are going to send you a survey to try and understand where each country is with the integration, and then we will use that information to see how to best support you. We are going to have a follow-on webinar in September, early September. So we'll be reaching out to other countries as well to share their experiences. We will send you an evaluation link, and I'm going to ask Kalibala to put it in the chat or Isaac to put it on the screen so that we can be able to evaluate this meeting. Your feedback will help us to improve the subsequent meetings. So with that, I would like to thank you very much. Please make sure that you evaluate us and give us honest feedback so that we can have a better meeting next time. We thank you so much for staying until the end, and thank you for being here. We hope that you've been able to get some ideas on how you can move into the integration agenda. We are very grateful to the interpreters and to PATA that supported the interpreters to do such a wonderful job. We also appreciate JPIGO for providing us with the communication platform, and we want to thank in a special way the organizing committee that has put together this meeting. So thank you, everyone. Have a good evening, a good afternoon, and a good morning. Bye.
Thank you.
Bye-bye. Thank you. Bye-bye.
Thank you. The link has been put in the chat, the evaluation link. So please click, don't go without evaluating us. Just a few questions. We want to make this session better. Thank you. We'll allow 1 or 2 minutes for people to click on that before we close out our meeting. Otherwise, thank you, everyone.
Well, again, what that time minute to